Alright, so our anti-arrhythmia drugs are going to stop abnormal rhythms, right? Typically, when you look at a normal sinus rhythm, you have your P, QRS, T, P, QRS, T, and you see that they're spaced appropriately, right? An arrhythmia is going to be where this appropriate spacing goes away. So here is a premature atrial beat. So you have P, QRS, T, P, QRS, T, P, and then another P. And so it's like a bam, bam. And then you go back to your QRS, T, right? You could also have your paraaxial atrial tachycardia. So that's just a whole bunch of beats real quick. And so it's P, QRS, T, P, QRS, T, P, QRS. And it's just like bam, 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 right? So tachycardia is when the heart is beating too fast. And then you can have atrial fibrillation, AFib, where you see lots of little p's, QRS, T, lots of little p's, QRS, T, lots of little p's, QRS, T. Typically, with your arrhythmias, like, the reason they're bad is because they are decreasing the overall cardiac output. They're decreasing how much blood is being pumped within a minute. And so that's going to cause stuff like decreased blood pressure, etc. So, a few more arrhythmias here. This one is a first-degree heart block. So you have P, QRS, T, P, QRS, T, P. A little too long right there. Like you skipped a beat, right? P, QRS, T. And so these PRs are getting longer, and sometimes you skip a beat in there. So with your type 1 second degree block, you're not going to have any QRS. So instead of just stretching it out, it doesn't go at all. So you have your increased PRs still, PRT, PRT, and then no QRS. Type 2 second degree heart block, you kind of see the same thing, right? So here you see your P, and then you get a dip before the QRS, and then back up, T, P, dip, QRS, T. And you see how that P kind of gets elongated there, and then skipping a beat. Third degree is you're going to have P waves that are no longer coinciding with your QRS. And so there'll be a P here, there, and so there's not a QRS between each one of them. And so your atria are beating a lot faster than your ventricles. Well, getting a lot more signals, because this is just looking at electrical activity. It's not actually looking at the contraction of the heart. It's just, this is the signal, the electrical activity in the heart. Alright, so we can break these arrhythmias down into two major categories if they are happening above the ventricles or below the ventricles. So with your supraventricular arrhythmias, it's basically anything happening above this AV node. So if it's AV and above, it is supraventricular, basically saying it's dealing with the atria, right? And so you get premature atrial contractions, and then you have your ventricular ones is going to be everything below the AV node. And you get your premature ventricular contractions. Ectopic foci, this is going to be an abnormal impulse of generation. And so it is a spot outside of your AV SA nodes that is causing a contraction. Typically, you're not supposed to have spontaneous depolarization outside of your two nodes. But with an ectopic focus, or foci, you have one. And so that can cause weird things like in this wave here. We have your P, QRS, and then whatever that is. And then P, yeah. So that's with your ectopic focus. So the contraction in the heart is kind of a mix between what you see in nerve cell conduction and skeletal muscle contraction. So here we have the influx of sodium rushing into the cell, right? So this is the depolarization of that cell. Then potassium on 1 through 3 is moving outside of the cell. So a bunch of positives come in to cause the depolarization, and then your positives are coming out. You can see that it takes longer for your potassium to leave the cell to get repolarized. And there's this plateau here that happens at 2. This is because calcium is moving inside the cell. So you have your depolarization, you start coming down, and then calcium starts coming into the cell. The calcium's really important in muscle contraction. It's going to allow the cross-bridging to happen between actin and myosin. And so this is important. And it allows for more calcium to come in, allows for a stronger contraction. And then we get back down to baseline. And then we wait for another signal to come and cause the influx of sodium. If this was a pacemaker cell, if we were in an SA or AV node, you would see that there's going to be a slow influx of sodium until you hit your depolarization, until you hit that threshold, and then it will kick off. What we're looking at right here in the dotted line is what a class 1A anti-arrhythmia drug will do. And so what it does is it slows the influx of sodium. And we'll talk about this when we talk about the different classes of anti-arrhythmia drugs. But it slows that influx of sodium. And then then you have your potassium leaving. Something to keep in mind about all your anti-arrhythmia drugs is that sometimes they can cause arrhythmias or make the current arrhythmia worse. And that's something called a pro-arrhythmia. And we'll talk about some of those in a little bit. Alright, so in our class 1A, so we have 3 class 1s. We have a 1A, 1B, 1C, and all 3 of them just block sodium channels. So all 3 of them are going to be blocking the sodium channels. Some of them do it better than others. So we have moderate, mild, and marked. With your moderate ones, your mild ones, and your marked ones, they all decrease that phase 0. So they bring it out, right? And we'll go through some of these drugs individually in just a second. Your class 2s are beta blockers. Talked about those before. Propranolol. Probably heard that one, right? Class 3 are potassium blockers. And then your class 4 are calcium channel blockers. So let's get into our class 1As, so our sodium channel blockers that offer moderate blocking. The first one, quinidine. This is derived from the cinchona tree. You may have heard of the cinchona tree before if you know anything about anti-malarial drugs. Quinine is similar to quinidine, and it's used to treat malaria. Quinidine, again, pretty similar in structure, but it is a cardiodepressant, so it just brings down all your muscle contractions. It has some anticholinergic and alpha blocking effects, which again is going to decrease contraction. It also gives you some of your side effects with nausea and vomiting and diarrhea, and you can get cinchonism if you get too much of quinidine. So overdoses with quinidine can cause tinnitus, that's ringing in the ears. It can cause salivation, headache, and even hallucinations. Another class 1A is procanamide. Also might sound familiar if you remember when we talked about Procaine, the local anesthetic. This is your most frequently used 1A. it causes nausea, diarrhea, anorexia, and possible skin rash. And is a pretty decent sodium channel blocker. Moving to our class 1Bs and 1As. We have lidocaine as our class 1B. So this one allows for moderate blocking. Or no, mild blocking. Yeah. Mild blocking, lidocaine. Doesn't work with atrial arrhythmias, so it's only going to be effective in your ventricles. So any subventricular or ventricular arrhythmias. It's really good stopping those ectopic foci. You can only get it IV or IM, so intravenous or intramuscular, unless you take Mexatil. Mexatil is just lidocaine that has been formulated orally. And so you can take that one orally. Does the same job. Type 1C is Tambocor or Rhythmol. Typically you don't use a 1C unless the other drugs aren't working. So they can increase mortality, they can increase cardiac failure, because these things give marked differences in sodium inhibition. And so they can inhibit it so much that your heart doesn't beat. You also have GI issues with it, bradycardia, heart block, heart failure. Our class 2 drugs are beta blockers. These should be familiar by now. We've talked about them for a couple different things. Propranolol. It's also a cardiodepressant, and so you can end up not pumping as much blood as you should because it depresses those cardiac muscles. It can cause hypotension, bradycardia, and mental confusion. Esmolol, or Brevibloc. It's a very specific beta one. So propranolol is a non-specific beta blocker, so it blocks beta 1s and 2s. And so it's contraindicated if you have asthma or breathing problems, because it can constrict your blood vessels or stop them from dilating. Esmolol is a specific beta 1 blocker, but it's used only in emergency situations, and which means it's only IV and it gets rapidly metabolized. So if somebody is having serious fib going on, you can give Esmolol to hopefully stop that. And then it gets cleared out really quick, so you have to re-administer it if it comes back. Our class 3s are going to be your potassium channel blockers. And so if you remember what potassium does is you have that sodium influx, and then the potassium efflux brings it back down to repolarize. And so these stop that. Cortisone, super potent. It is a sodium blocker, like our class 1s. It is a beta blocker, like our class 2s. And it's a calcium blocker, like our class 4s. And it's a potassium channel blocker. So it blocks, like, everything, right? It's also an alpha blocker. So, cortisone, super, super potent. It really does block a lot of stuff. Taking it orally, it's incomplete and variable, so you're not going to absorb all of it. And how much you absorb, you might absorb a little or a lot. We don't know. It depends. It also has a really long half-life that is also variable. And so it can last anywhere between 1 to 3 months. And so if you're taking this thing daily, some days you're getting a lot, some days you're getting a little. Who knows how fast it's getting out of your system. And so you really have to do a lot of metabolic testing to check for the plasma levels to make sure you're getting not too much of this stuff. Side effects: dizziness, tremors, ataxia. Pretty par for the course for a lot of this stuff. But it can also influence your thyroid function, because it's pretty similar in structure to thyroid hormone, T3, T4, and it carries an iodine on it. And so it can either cause hypothyroidism or hyperthyroidism. It depends on the person. It can also cause pulmonary fibrosis. It can also cause a heart block, heart failure. It can cause proarrhythmias, like torsade at the points, which is what this is showing, where you get this bouts of tachycardia without normal waves. It can also cause you to get bluish gray skin and even corneal microdeposits, and so on and so on. So, very potent, comes with a lot of side effects, pretty risky. Don't use it unless you have to, right? Beta pace. This is a non-selective beta blocker and a potassium blocker, and when we see the side effects, it's pretty similar to beta blockers. So lots of hypotension, possible diarrhea kind of stuff. Corvert and Tickerson, these are both specific potassium blockers, really good at stopping AFib. And so when you get that dipole, it's going to extend out that repole and works really good for your supraventricular fibs. Our class 4, these are going to be your channel blockers. They're working specifically on your SA and AV nodes and overall decrease the heart rate. And so they interact with the funny currents. Also dilates the vessels, and so it helps with angina. And so you don't get that chest pain because the heart is getting enough blood. A lot of these, like your beta blockers, will also help with angina by decreasing the overall workload, which we'll talk about in a little bit when we talk more about angina and drugs that stop angina. Side effects: headaches, dizziness, constipation. It's also cardiodepressant and should not be taken with other cardiodepressants. So some of these drugs you can take together, like if you can take a beta blocker with a sodium blocker if you need to. And then we'll talk about some other drugs in the coming weeks, like diuretics that you can take that also help. Cardizin, pretty similar to Veramapil, but it's better at vasodilation, less cardiodepressant, and so it's going to decrease that angina better, and your heart is going to pump better, and so typically choose that one over that one. And then adenosine, only in emergencies, IV only. You may know the name adenosine. It's part, right, ATP, adenine triphosphate. Adenosine is a metabolite of that. And what it really works on is that paroxysmal supraventricular tachycardia that we looked at earlier. Right here, where you get lots of dipoles going back to back. This stuff is really good at stopping it. But again, only in emergencies. Alright, the next group is going to be talking about angina and anti-anginals.